Horror stories have come out of cities like New York and others with large minority populations about how Blacks and other minorities have died of COVID-19 in disproportionately large numbers. At the same time, recovery from COVID-19 in Africa seems to be disproportionately higher than other parts of the world. This webinar highlights some of the issues that might explain this conundrum. The first question I seek to ask the panelists are to understand why there's a disparity in outcomes between Black patients who fall ill with COVID-19 and are admitted in hospital in Africa and those admitted in the US or UK or the diaspora in general. What is happening in the city or institution where you work that may help shed light on this question? So I'll ask this question of each of the panelists. Please introduce yourself and tell us about what's happening in your experience. Dr. Rumbi, could you please start?
My name is Rumbi Mkurajija. I'm a surgeon who has an interest in bariatric surgery. Thank you so much for organizing this webinar on such an important topic, especially at this time. In terms of the questions that you asked, I think the CDC around June had reported that in the US, 22% of the deaths in COVID-19 were in Black patients, despite the fact that Blacks make up 12.5% of the US population. Now, while these numbers were certainly distressing, I think for anyone who has had an interest and paid attention to the issues around disparities in the US with access to healthcare, these numbers were certainly not that surprising. Now, whether this translates to the question that you're asking with regards to outcomes between patients in the US at least and Africa, I think there are some factors that are playing a role. But in the US, it has been widely reported that there are multiple areas of clinical care where patients, minority patients, and Black patients in particular, are not receiving the equitable care that is being given to other patients. Some examples I'll give you briefly are in cardiac disease. Black patients who present after a heart attack take a longer time from their arrival to life-saving intervention, and this results in decreased survival from those events. The same thing is seen with cancer outcomes and delayed treatment of their disease, or in trauma and infant mortality. And I think all of these factors that have been previously identified as problematic are the same things that we're seeing with the COVID-19 pandemic. The reasons are very complex, and I think mostly rooted in the social and injustices that people are experiencing that are leading to access to care that is not equitable. Patients experience racism when they try to access the system, and this changes patients' experience and makes them less likely to seek care early and less likely to establish care with a primary care provider, which makes sure that at baseline, the population is healthy. When you think about the comorbidities that we know increase the risk of having severe COVID-19 infection, in the US, minority populations and Blacks in particular carry a disproportionate burden of these diseases, things like diabetes, hypertension, heart disease, obesity. And I think a lot of that is related to the social determinants of health. If minority populations are living in areas where they don't have access to healthy foods, they're more likely to consume foods that are high in fat, sugar, and salt, all of which lead to some of the concerns that we're finding with heart disease, as well as diabetes. If you think of the area of interest I have as obesity, all those factors play in with patients having increased comorbidities and underlying chronic conditions. So I think addressing some of those issues, at least for the patient population in the US, will be a huge factor with getting us to a place where patients are receiving equitable care.
Thank you, Dr. Rumbi. And so next we'll go to Dr. Charlie Eastman.
Thank you. My name is Dr. Charlie Eastman. I'm a medical doctor, and I've been interested in pandemics for a long time.
Okay. Could you tell us where you are?
Yeah, I'm in London. So I run a private medical clinic in central London in Harley Street, and prior to this, I studied at the London School of Hygiene and Tropical Medicine in public health, and also at Liverpool to do a diploma in tropical medicine. So the UK and the Europe perspective is very much that Black populations are more likely to acquire the infection. Certainly a prevalent study on antibodies showed about 17% have been infected compared to about 13% of non-dark-skinned people. And also there seems to be an increased mortality. And what was very evident in England especially was that the first wave of deaths of healthcare workers were all Black and Asian, you know, the first 10 or 20 people. And that raised huge questions about who's in the front line, whether those in the front line had adequate protection, which obviously in retrospect, a lot of them didn't. And I think there are a lot of issues there about how our health service is constructed around a lot of dark-skinned people who often are in the front line, but often equally don't get the best protection that's possible. I think going forward, the issues are, as my colleague said, very much about the socioeconomics of this disease. And this disease is going to affect those with pre-existing conditions much more than others. And it's also going to affect those who are obese much more than others. So because those things are more prevalent in dark-skinned communities, that's a problem. A colleague and I are doing a documentary around this where we ask a key question: is COVID-19 a bullet or is it a guided missile? And so from a practical point of view, if you think it's a bullet, it should affect everybody equally. If you think it's a guided missile, then you could see that it would target particular groups more favorably than others. So there are some very complex political, social issues involved in this disease. It will be with us for a long time. WHO are saying that they think it will be with us for at least 2 years. We have an independent group of government experts called SAGE, and they reckon, one of their experts reckons it will be with us forever. So you've got everything from 2 years to forever. So we've all got to adapt. My theory about Africa and some of the countries in Africa is that the demographics certainly help, because you've got a younger population, and we know that the disease is more deadly and more likely to cause illness in those of an older age group. So the fact that Africa has so many young people, or many African countries, is a benefit. Also, probably the fact that overall, the African, in many African countries, is a fairly healthy individual, whereas the African in many other parts of the world, for socioeconomic reasons, is already burdened with other diseases and illnesses, which COVID then comes along, and it's like the last gust of wind that makes your sails fall off the cliff. So I think we've got some huge challenges ahead around continuing with hand washing, sanitation, social distancing, all those sort of advice issues. And Africa shouldn't be complacent, because this disease will spread, and there's a lag time between when it hits country A, country B, country C. So there will be, I think, significant increases in mortality in Africa, but hopefully not as bad as it has occurred within the poor parts of the Western economy.
Thank you very much, Dr. Easton. We'll now pose the same question to Naomi Carpage.
Thank you for inviting me to participate in this important conversation as well. I am Naomi Carpage. I'm a nurse leader who is passionate about nursing and the role nurses play in the health of our community and people, regardless of their color and their status. I work at a 400-bed community hospital in Arlington, Virginia. I am the Associate Vice President for Nursing Operations at the hospital. I oversee a team of about 500 nurses and ancillary staff who provide care for patients on 10 medical surgical units, telemetry units, as well as an inpatient rehab unit in a 28-bed ICU. About 25% of my team are people of color, either immigrants, minorities. And at the height of the pandemic in our hospital, we had over 120 COVID patients, either in our medical units or in our intensive care units. We were seeing about 20% of the patients then go into the ICU initially, and now that's down to probably less than 10%. It didn't take very long for us to notice the disparity in the COVID patient population. We noticed we're admitting a higher percentage of people of color. For us specifically, the Hispanic and Latino patients. Arlington County in Virginia, where my hospital is located, is an affluent community with a diverse population. The Hispanic Latino population is about 16% of the community, and African Americans make about 9% of the population there. Yet between the two, they now make up 50% of the people affected by COVID in the county. Our Hispanic population has been hit really hard. Over about 40% of the people who've tested to COVID in the county are Hispanic. As you've heard already, in the US, about 12% of the population is African American, but we're making up over 20% of the people with COVID. And death rates, if you have COVID and African American, is 2 times higher for you as well. So clearly a problem for us. Sadly, in the US, again, race and ethnicity risk markers for many underlying conditions that impact your health, including COVID. I think you heard earlier on, the conditions that increase your risk for hospitalization include hypertension. If you have hypertension, you're 3 times more likely to be hospitalized for COVID. If you have diabetes, you're 3 times more likely to be hospitalized for COVID. Obesity, if you have that, you're 3 times more likely to be hospitalized for COVID. Chronic disease, kidney disease, 4 times more likely to be hospitalized. If you have severe obesity, 4.5 times more likely to be hospitalized for COVID. If you have 2 or more of these conditions, your risk is now 4.5 times to 5 times again. And age is also a factor. So now say, stop and ask yourself how many people of color you know with at least one of these risk factors on top of that. Hypertension, diabetes, and obesity are not only increasing our risk for COVID, but have increased our risk, as you heard earlier, for other diseases. So heart disease, stroke, kidney. So we're being hit multiple times here. Other markers that, obviously impact this include socioeconomic status. If you can't afford the basic healthy things you need to eat, it's going to be a problem for you. Your access to healthcare if you don't have it. Your distrust of the healthcare system. If you're worried about your immigration status, so you're not going to go to the hospital. All these are things that we're seeing as issues here. And then our occupation and has an impact. Many of us are frontline workers. When it hit, we have to be at work, right? Essential workers like your housekeeper, your food service worker, your grocery store worker, all have to be there. And many didn't have the luxury of working from home. We told everybody stay at home and work from home to be safe, but many did not. They have jobs that require them to be out on the front, so they had to be there. So basically, as you've heard, the years of systemic racism and discrimination has been an underlying cause of a lot of the health disparities that we're seeing. While it is not new, COVID has sort of brought it to the front end to everybody again. We're seeing that the difference is that with COVID, we're seeing the deaths that we get out of this much more quickly than things, the other diseases that we've been suffering from. I want to sort of talk a little bit about the fact that, so even though this feels like there's nothing we can do about it, I believe there's things we can do about it, right? We've got to do everything when the risk is there, but we have to do everything we can to avoid getting the virus. So basic things like mask wearing and social distancing and hand hygiene. As again, you've heard, it's critical and we have control over that and we can do that. Advice that we give our work to staff, because again, I'm very worried about my staff as well, not just our patients. We realize that if our staff can't work, we can't take care of our patients. So we've got to make sure that they're safe as well. But advice that we give them, always weigh your risk before you go out there to go do things. So check in to say, should I do this at all? Am I going to be with people that I can be safe with? Can I do this outside? Can I wear a mask? Those kind of things here. And we strongly, if we did something that was important, work on making sure that we're protecting our frontline and essential workers. So issues that you heard about PPE, how to do it, how to make sure that they have the information that they need, were some of the things that we were doing.
Thank you very much, Naomi Carpech. And now we move to Dr. Nana Mintaganza from Ghana.
Hi, my name is Nana Mintaganza. Good afternoon, everyone from here. I should say good morning and good evening since the global community. So I work as a medical doctor at the University of Ghana Medical Center, and I'm with the COVID-19 case management team. And I should say that, once we all heard about COVID, even before we recorded our first case on the March 12th, we were actually putting measures in place because the whole thing was scary. The fact that people were just getting the disease and just dying, it scared everyone. So we were putting extensive measures in place. So once we got our first case on the March of 12th, there was a sort of mechanism instituted where we had enhanced contact tracing. So we do the contact tracing, we test, and then we treat. So this in a way helped us get ahead of the disease. Because what happened was that the main focus here was getting or capturing the disease early. And as we all know, issues with the respiratory system, once you get it early or once you are able to capture it early, managing it becomes way easier compared to having a patient stay home and coming in very late. So the whole lockdown thing wasn't just a normal lockdown for us. What we did was we decided to map the COVID-19 hotspot areas, and we had a mass testing done in such areas. So we go from house to house, we test people, and after testing, people who tested positive were actually allowed to see the medical practitioners. So what we also did was that we had two separate areas. We had treatment areas and we had isolation areas. So if you test positive and you can't self-isolate at home, then we move you to the isolation areas, because we know that you test positive, probably you'll be asymptomatic, but then the next person who gets it might actually show symptoms and it could get very serious. So we move you to such isolation areas. And patients who basically have moderate to severe diseases, patients with comorbidities, high blood pressure, I would say hypertension, diabetes, asthma, and sickle cell disease, who have uncontrolled disease or unregulated disease, were also basically seen at treatment centers. And we also put our focus on pregnant women as well. So if you're a pregnant woman, whether you're symptomatic or asymptomatic, we usually don't want you to tip. So what happens is we admit you. And the good thing here was that the healthcare provided was basically free. So in Ghana, one thing that we noticed prior to COVID-19 was that people would usually not report to the hospital for diverse reasons, but mainly because of the cost involved in treatment. But then with COVID-19, the government instituted this policy that they were basically going to give free treatment to everyone, and that actually helped. So once we pick up the condition, we decide where you're going to go. If you're asymptomatic, then you're going to go into isolation, where you've got nurses there who would examine you, check your saturation every now and then, just to be sure that you don't tip over. And then those who basically have symptoms, moderate to severe symptoms, we will allow you to come to the treatment center, where we provide free services ranging from the cheapest of services such as medication supply, vitamin T, zinc, to more expensive services like chest CT scans and even free intensive care unit services. So that actually helped a bit in getting people to come forward to get tested. And what we also did here was that when you check per WHO standards, usually they will decide to start oxygenation when your saturation falls to about 90. But we realized that once you go below that, then you have the lungs collapsing, and then it gets very, very difficult in getting the patient back. So we usually look at 94% of oxygen saturation. Once you fall below that, we quickly come in and then we start oxygenation. And we realized that that also helped in terms of keeping our patients fit, and then in terms of increasing our recoveries. You check our case numbers now, we're doing about 43,000, but then we have about 41,000 recoveries, and our case mortality ratio is about 0.6% compared to the worldwide 3.5%. So such measures, really help the enhanced contact tracing, early testing, and then deciding to keep patients in isolation centers and then treatment centers as well. Also, the care system in Ghana is such that we we focus on equity. So in my institution, University of Ghana Medical Center, that is one of our main focus, because we had patients coming from other places. We didn't have only Ghanaian patients. We had non-Ghanaian patients coming in, and we noticed that people who were coming from Asia usually come in with a severe form of the disease. But even that, we realized that recovery was great. Once they stay on admission for about 7 to 10 days, they tend to recover. The equity of care was there, and it was standard. If you need a usual treatment, we'll do that for you. If you need ICU care, we make sure that you get it. So, I mean, that also really helped in keeping our mortalities actually low. What we're currently doing is that even though we have a place where we admit, we also haven't forgotten about people who would want to come to the outpatient department. So the University of Ghana Medical Center, we basically run an outpatient department for COVID-19 patients. And in a day, we see about an average of 20 to 30 patients. And we do that to see if anybody will need admission. And those who wouldn't need admission, we basically track them. So we have systems put in place. There's this particular system we call COVID Connect, where we have our patients logging onto the system. They put in, or they key in their daily vital signs, temperature, respiratory rates, and all that. And we've got like a team of doctors assessing these vitals. And if we realize that you need help, we quickly call you and then we intervene. So the COVID Connect was actually very, very good. And through that, we were able to capture a lot of cases. We instituted management early, and then we had some form of success. I wouldn't say that it's been excellent, because we've lost people. We've had about 261 people passing on. But when you compare it globally, you see that we are not doing so bad. And you can actually extrapolate this from Ghana to the rest of the African countries as well, because you see that the recoveries are great. I mean, there's been so many explanations for that, but we're still doing studies to just see if indeed the whole malaria, hydroxychloroquine thing plays an effect, because people have actually said that, well, because our system has been exposed to some form of malaria, and then we've had this chloroquine, hydroxychloroquine in our system, that could be the reason why we are doing well. We can't really put a finger on that now until it is established that chloroquine, hydroxychloroquine is actually good for COVID. But you can also say that looking at our population structure, as Dr. Easton said, we have more of a younger population. So in Ghana, we've got about 38% of people within the age range of 0 to 14. And that forms more of like a broad-based pyramid. And we know that COVID would usually affect the elderly. And because of that, we can also say that we can deduce from that we are doing great, because we've got only 14% of people here aged 55 and above. So that could also explain the success that we've had in terms of dealing with COVID. But all in all, I think that it goes beyond science. It's more of the social factors that were put in place, that were instituted. The fact that care was given and care was equitable and everybody got access to good care, and it's still free for everyone who has COVID. Once you have COVID, we see you and then you don't pay any bill at all. And that has been very, very paramount to our success. Thank you.
Thank you. Thank you very much, Dr. Minta. You have outlined a very efficient and effective system for treating COVID. And I have two questions. One is, have you ever had too many patients, so run out of beds? And then the second is, what is your treatment regime in terms of medication which you give to your patients?
All right, thank you very much, Ambassador. So yes, in my institution, we have been lucky. So the University of Ghana Medical Center is actually a new institution, and it's big. The capacity is about 700. So I should say that we have been lucky in terms of having space to keep patients, because what's happening is we even have a space for suspected cases, and we even have a space for people who actually have COVID. So even people who haven't been tested but are seen to have the symptoms have a place to stay. And it's a referral site. So other places where who have shortage of beds and all that refer to us. And it's been good. We always get space for everyone who comes in. We don't turn anyone away. In terms of treatment, so we are doing the usual azithromycin, 500 milligrams daily for adult patients. And we are doing vitamin C. We are doing zinc as well. And we are also doing our anticoagulation. So this is actually dependent on whether the patient is going to stay in the hospital or the patient is going to be seen as an outpatient. So once the patient is going to be in the hospital, then in addition to your vitamin C, zinc, and azithromycin, you have to start your anticoagulation. Also, the study on steroids has been very beneficial. So we are actually instituting the use of methylprednisolone or dexamethasone for our patients. The results have been remarkable. And the fact that we start our oxygenation of patients quite early as compared to other places has also been very, very, very helpful.
So you don't administer any type of chloroquine?
No. Okay. So with the advent of COVID, as part of our initial treatment protocols or guidelines, there was hydroxychloroquine and then chloroquine phosphate. So we started that, but because of the side effects, the effect it has got on the heart, we kept doing studies. So when it was also backed by external research that hydroxychloroquine, chloroquine phosphate tends to have some effects on the heart, what we did was we decided to put a hold or put a stop to using hydroxychloroquine and chloroquine phosphate. And then we managed our patients without that. We did a comparative study and we realized that there was no change at all in terms of management. Patients, the outcomes were still good, whether you were doing chloroquine, hydroxychloroquine, or without that. The outcomes were perfect. So we just decided to keep that somewhere just to do away with the side effects. And we are not doing that anymore. It's been good.
Okay, thank you. Does any of the panelists have any questions? And if not, then we'll go straight into the town hall and have our participants ask questions to the panel. Dr. Ismon.
Yeah, no, I'm just saying, I think the Ghanaian treatment sounds very impressive in terms of the use of vitamins as well as the use of anticoagulants, because what we know about the disease is it's a major factor in this disease about coagulation. And so they sound like they're, in my mind, top of the game, really. So well done.
Thank you very much, Doctor.
My name is Grace Clark. I am a nurse educator and also a bedside nurse at Redlands Community Hospital. I work on the COVID unit. So I'm really excited about the Ghana treatment plan. I've just nodded my head everything you were saying. So that's really, really exciting. But like I was saying, your last name brings me a lot of secondary school chemistry. I don't want to call him excitement, but my chemistry teacher. But my issue, since we're talking about health disparities, my question is, in Ghana, we don't have race. Ours is that of class, the have and the have nots, the great middle class. So my question then is, for my people in Isiama and far away from Accra, how are they benefiting from access to testing, preventative education, and how are they being included in this treatment or prevention? But I have to say, it's been really, really great to hear what you were saying. So
yeah. Thank you very much. So Grace, so what I'll say is it's actually a national thing. It actually cuts across. So basically, this whole initial lockdown phase that we had was national. People had other views that they would prefer we map it more on the hotspots and then test and treat people, but we actually went national, and it helped. And the education was massive because it was on every radio station, it was on every TV station, and I should add that the military police also helped, because once we see you outside during lockdown, you're in trouble. And even with the whole face mask issue, we see you without face mask, you're in trouble. So the education was actually national, they cut across. And in terms of receiving care, as I said earlier, the care is equitable. Every institution, so basically every district has a district hospital, and every district hospital sort of created more of a makeshift building for COVID, because we thought it was just a wave that was just going to go. So they created more of a makeshift building. You have tents and all that, but then the personnel were there, and government ensured that every single institution had PPEs, even though sometimes you have the issues of no PPEs. So when that happens, then it means you would have to refer to a higher facility where you've got PPEs. And must I add that, every region has got a regional hospital, and the regional hospitals are well equipped to deal with issues of COVID. So if you should see a case in a district hospital and you're not so comfortable, you'll quickly refer, and then the regional hospital takes that up. And through that, the success has been great. I should say that at University of Ghana Medical Center, even though the facility is so big, we haven't been burdened with so many cases because the other facilities in the other regions are doing well. And that's, tells us or shows us how much everybody is putting in effort and pulling its weight to ensure that COVID management is national and equitable.
Thank you.
Thank you. Do we have any other questions?
Hi, Johanna. It's Joyce Sarfon here in London. Hi, thanks very much to everyone for a great webinar so far. And it's really heartening to hear the efforts that are being made. Just going on what Grace, her question regarding preventative measures, just wondering from like preventative to sort of build up the immunity, what kind of advice should we be hearing or adhering to in terms of making sure that we're keeping our health at an optimal as can be. Yeah.
Did you want to direct your question to a specific panelist?
Okay, maybe I'll direct it to Dr. Eastman.
Thank you. Yeah, you raised an important question. I don't think we know the answer. It's a simple response. There is an issue, or it seems to be an issue with vitamin D. And we know that dark-skinned people outside of Africa and in cold climates have lower levels of vitamin D. And it does seem sensible to maintain your level of vitamin D, whether you've been tested and found to be low or not. So I'm an advocate for people going to a health shop and getting vitamin D. It doesn't cost a lot of money. You can also spray it. It's harmless and it may be beneficial. But the data on it, I think, is fairly limited unless another panelist can tell me something different. I think obviously we've said about predisposing conditions. I think that given that this disease will be around for a long time, there's an issue for everybody to look after their own health in a more general sense. So those of us who don't do enough exercise should start doing more exercise. Those of us who've noticed that our waist is increasing in size should make every effort to reduce our waist size. And so for the chaps, it's certainly, almost like going to the tailor and saying, well, why am I 34 when I should be 32? And same for women in other ways. So I think there's a lot that we can do ourselves at self-help that will probably just give us an edge on this disease.
Thank you.
Pleasure.
Thank you very much, Joyce Sapong. We have a question from Kwesi. In the USA, there seems to be a high distrust for vaccinations and government mandates, especially in the Black community. Are there certain things that can be done to increase the level of trust between the government, medical workers, and patients? I'll direct the question to Dr. Rumbi.
Thank you so much for that question. And that's a really important question, especially now with all this focus on developing a vaccine as a way to control COVID-19. But there is so much distrust in the healthcare system in general, not only thinking about vaccine prevention of different diseases. And when I've talked to different colleagues, the sentiment I've found from a lot of my colleagues has been, that the community overstates their concerns with whether the healthcare system really is serving them. But at least my experience in learning about different things that have happened historically, so things like forced sterilizations on minority populations or unethical experiments that were done, you understand why these communities have the feelings that they have about the healthcare system. And I think a big factor that perpetuates this kind of distrust is the fact that the healthcare system doesn't really reflect the population that it's caring for. So when you think about the practicing physicians in the US, the vast majority are Caucasian or white, and only 5% of those physicians are Black. And even as you break it down to the different specialties, those numbers go down. And when you look at different practitioners, say in research, in vaccine development, in healthcare leadership, those numbers go down even further. So I think including minorities as part of all these research efforts, part of the healthcare leadership, will help communities see that they're represented and that their concerns are considered as most of these projects move forward. I know a lot of institutions have developed many social outreach programs. When I was in Boston, there was a very big effort to include community members as part of the hospital programs to build trust with these different communities so that people had more transparency and understood what was going on with all these vaccine development or with promoting different preventative measures.
Thank you. Might I add that the politics of healthcare in America is also very daunting, with people marching about human rights when they're supposed to wear their masks, and conflict between the chief executive and the head of disease control, and that doesn't inspire confidence. In addition to some of the things you have outlined. Do we have a question from Joel?
Joanna, may I add something?
Yes, please.
Okay. Just another, perspective. I couldn't agree more with everything you're saying, and Dr. Rumbi. The truth of it is that the people of color have a reason or have been given reasons to not trust the system, but they need the system. So there's multiple things that I think we can do. Nursing has more people of color, which is great and helpful there. And nursing is one of the most trusted professions. So I think as nurses, we have a way of stepping in and helping with some of this education and communication about what is needed. We need our people to be part of studies so that the results of the studies reflect us. Because when studies are done and we're not included, and we're trying to be treated based on that, it doesn't work. So it is us trying to, listen here, having more physicians of color is critical.
Yes.
People need to feel comfortable going to someone that they trust that is going to proactively take care of them. That's critical for us. We need more people of color in leadership roles so that we can, have an influence or a voice in decisions that are making in our healthcare system that's affecting people. So that has to happen as well. But definitely every chance we get as nurses, especially, I take a lot of pride in the fact that the nurse at the bedside spends more time with the patient than almost anybody else, using that as the opportunity to explain to them why this vaccine is important and what are the risks, and being honest and giving them honest feedback, I think will be some of the things that can help us.
Thank you so much, Naomi. Do we have any other comment or question?
Yeah, I would just add that Heidi Larson at the London School of Hygiene and Tropical Medicine runs a whole program around the lack of vaccine confidence. So if you go onto their website, there's a lot of useful information. The other thing we've got to face is the fact that it's in the interest of the Russians and various other troll agencies to make people anti-vaxxers. So there's a whole social media experiment going on, which is designed to create distrust in vaccinations in general. And we as a medical profession are up against that as well. And so there's a huge challenge for the medical profession, yes, based on sometimes historical mistrust over things that it's done, or certainly racist things that have been done. So this is not going to be an easy battle.
This is Joel Ruffin. Ambassador, just want to underscore Dr. Eastman's comments. It's a multi-dimensional warfare. I mean, from, in America, the constant need for trying to achieve physical health, mental health, spiritual health, trying to identify where you are in the broader conversation. This distinguished panel, I mean, I'd be pressed to identify any program on TV where I see this many physicians of color together talking. You don't see that at all, and so, yes, and so then you have individuals in our community who may not be doctors, but come up with their own remedies. If you do this, you do the come to these home remedies and these herbs, and everyone's saying, if you take this, you take that. So you have this information warfare going on, and it's really overwhelming. I mean, it's really overwhelming. And then you have this spiritual aspect where God will heal you. You don't need to do the X, Y, and Z. And so it's really a tough balance, and it really takes that to establish an authentic voice, the visibility, and all the remedies that were identified here. But it needs to be some type of almost coordinated global medical agenda for us as a people to be able to fight this. It can't happen as like one-offs because it's too massive. It's multidimensional, it's evasive, and I'm happy and encouraged by what I'm hearing, and by just, again, this distinguished panel, because it's really something we need to address aggressively.
Thank you. Thank you very much. I see you, Kwashi. Did you have a question? Your mic is off.
No, I was just nodding very enthusiastically. This is Hugh Kwashi in London, by the way. Just nodding with what Joel had said. I was, for me, this is, I think, a learning process more than a teaching process. I defer to the distinguished panelists with their medical knowledge. I'm only a pretend doctor on television, after all.
That is amazing. Of course, you're Dr. Rick, aren't you? Does Dr. Rick have to treat COVID patients?
Oh, well, no. This is I suppose I shouldn't tell you this, but I will. We will be introducing a COVID-aware episode later on this year. For all those who don't know it, there's a series called Holby City in which I play a leading surgical consultant. The last episode, I was in a coma. I shall wake up from that coma in the world of COVID. And so we shall play an entire episode in full PPE. No, it is something that, of course, exercises us all here. And the government here has been woefully incompetent in dealing with it. And the worry is that the information has been doctored, has been manipulated. They're trying to minimize the figures of it, the rate of infection, and indeed the mortality rates. So it's difficult to know precisely what the situation is. Currently, the R rate in the UK has apparently gone up to about 1.1, I believe. And there are local shutdowns. And the problem is, the constant debate is whether you are balancing livelihood against life. And if you shut down the economy in order to try to contain the disease, and of course people will lose income, and there will be a spike in unemployment and all that brings later on in the year in terms of social benefits and no doubt of crime, and actually people ignoring the lockdowns and causing further outbreaks later down the line. So this is a time to learn and to make the best strategies available. I mean, I'm very impressed with what appears to have happened in Ghana. I wish we had comparably competent leadership in the UK.
Wow.
Thank you so much. So we have a question from Theodora Richter.
Hi, my question was that I hear that in Ghana, in addition to what they're doing in the hospitals, they're also using some local remedies that seem to be helping in addressing the COVID issue. And I was wondering if one of the panelists could speak to that.
Or maybe a member of the audience. Does
Yeah.
anyone use local remedies? Does anyone know about the local remedies used to is it boost immunity or cure COVID? Which of them?
My understanding that it was to boost immunity, and also patients that are getting COVID or drinking. One of the ones I heard of was they're taking the outside of the pineapple and ginger and garlic and all sorts of things and making a tea that they're drinking, and it seems to be working. So I was wondering, has anyone else heard of this or any news on that?
May I say, this is Hugh Kwashi again. I did see, I'm sure you also saw a clip, I think on YouTube, of a couple of con men selling stuff which was supposed to be a COVID cure, which induced severe and prolonged diarrhea, which they said was a way of ridding the body of all the toxins. So I would just urge caution on the use of uncertified local ingredients.
Sure.
But of course, there is the center, or there used to be the Center for Research into Plant Medicines in Ghana. I'm not sure whether they've produced anything, but anything else I wouldn't trust.
This is Naomi, just adding a little note. I think we need to be careful about things that, as Joanna said, traditionally, they're good for you, right? You're immune, but they're not necessarily curing anything. I think sometimes we use the words cure. So the majority, even in the US, of people who have had COVID either have no symptoms, which is how it spread the most, mild symptoms where they stayed home, then the few came to the hospital, probably 20% of them came to, and then even a smaller amount of those people got hospitalized. So it's possible for you to have COVID, drink water, do nothing else, and get better. It's what you need to do. So things like what we're talking about in Ghana is actually known to be good for you, but I don't know if there's any scientific that it actually cures COVID. So far, we don't have a cure that I'm aware of.
Yeah, I mean, what I would say is staying rehydrated is a critical thing when you are unwell. So all these things encourage you to stay rehydrated.
Yeah, and I would back up my colleague on that, because the whole reason that we got randomized controlled trials was to show that sometimes things that people thought were beneficial sometimes aren't or make no difference. And in a complex situation, it's understandable that people will take local remedies, but there's no evidence that they're actually beneficial.
This is a question for the panel: is how do we use this moment in time when we have this focus on COVID-19, thinking about our health, seeking answers, and how do we use this as a platform to forward this awareness? Because COVID is just one of many to come. And COVID may be, affects our bodies, but there are also parallels in our thinking. They're just as viral and just as dangerous. But how do we use this as a platform to kind of discuss health just comprehensively, and to keep that awareness, to establish these voices of, establish our own voice, own authorities, as well as validating these kind of localized remedies where we can trust the information that's coming from our own wisdom that we're curating within ourselves.
Joel, I'd like to take that up on the sense that I think we need a specific Black health movement. Yep. And I think that that's entirely doable. We need to set up the right team of people to get it going. I tried to do something a few years ago in the UK where I said to people, look, gone too soon is a ridiculous thing to accept as a society. You know, every time there's a funeral, it's gone too soon, gone too soon, gone too soon. And some of the gone too soon is nothing to do with the medical profession. It's to do with habit and lifestyle. So if someone didn't bother to check their blood pressure, or did check their blood pressure and found that they had high blood pressure but didn't take their medication, that's not the fault of the medical establishment. That's the fault of the individual or their ignorance. So that's another example. Another example is in the African culture among the men, it was very accepted that the men had a huge pot belly to show that they'd done well. Wow. Now, you translate that to the Western economy and you tell an African man to walk around with a big gut, you're asking for trouble. Wow. And we need to re-educate ourselves about that basic fact. Then the other thing we know is we put too much salt in our food. So again, this is a very simple thing to remedy, too much salt, too much sugar. So there are nutritional things that we could do as communities of Black or dark-skinned people that would hugely improve our health. And we don't need the surgeon, the doctor, the specialist to tell us that, but we need to do that as a community. So I think a Black health movement that focuses on those very simple issues will be overall beneficial.
It's incredible. I love it. Yes, absolutely. Absolutely.
And just to agree with that statement, I think as communities, we could do a lot more to support healthy habits. So just making sure that in communities of color, children have play areas where they're not indoors all day, confined in front of a TV, that they're actually getting involved, being more active, making sure that, you know, a lot of organizations have taken it on, churches or other community centers, to do those blood pressure screenings. So patients, say in the US, who don't have health insurance and are concerned about going to see a physician, have easy access to at least get the diagnosis and get things going. So I think communities can partner with individuals in trying to advance some of these efforts.
I would like to add that in talking about communities, I mean, Ghanaians and Africans, we like going to church a lot. So I think healthcare workers, healthcare providers, experts in health, I mean, there's a lot of people holding big degrees in these churches. And I think there should be a platform where we share, like what Dr. Esmond was saying, to be shared in the churches. I mean, the church potluck is just a disaster waiting to happen. So it will be incumbent upon us as experts in whatever field we're in to take this knowledge that we have and promote it in our communities. You know, I don't know how we can break into the church with this messaging, but I think it would be great to do that. And I also want to...
One thing quickly, Grace, I think the idea is good, but there are two things that are problematic. One is in the UK, we've had Black pastors selling fake coronavirus cures. We've also had pastors telling people, you know, not to bother and that, you know, God will provide and all of that. So you kind of, you know, there's a pro and a con, like all things. And yes, if we can go in and partner with sensible pastors, but we also have to be aware there are some very powerful pastors who really are anti-vaccine, anti-this, anti-that, and you know, we're not going to get anywhere with those ones.
Yeah. And I was going to add, Grace, that if you look at us, if we took three of our biggest issues in Black community, hypertension, diabetes, obesity, just those three, and focus on it, many things that are affecting, we will become a healthier community. It is hard. We all know it, right? It's hard. Sometimes the diets we suggest to people are just not the food they eat. So we offer them a diet that's not going to work. They're not going to eat it. Myself included, I hear exercise and I cringe. I realize that I'll do better if I think of movement. I have no problem moving. I just don't like the word exercise. But those are the things you have to learn. I had to enlist my cousin, who's much more disciplined than me, to get me out of bed, to go get out there and go walk, right? We have to, as a team, realize that we have control over this, but we have to do it together, and we have to do it in a way that makes sense to us, not the way others suggest to us. And that's why sometimes it doesn't work.
I will add to this. As a nurse, right? You know, I have my patients, and it's like, oh, you are diabetic. Eat this many carbohydrates. Eat this. And my patient was a Ghanaian gentleman, and I sat there and I started laughing at him, and I said, we were laughing together, like, how many carbs are in fufu, to be real? Let's just break it down.
Probably 2 days worth.
So I was like, well, if a bread is 15 grams, how much? And by just having that conversation, so just handing him the pamphlet that said, eat broccoli and eat this, he walked away at least telling me that he now understands what he needs to do. But at that point, in the same healthcare disparities, it come a bit too late. Now this young man is on dialysis and so many other things. And access to early health care and medical care, period. And often when we speak of immigrant care or health, we often think of our brown brothers and sisters from South America and things. But we Black people are here. We hurt too. So sometimes, you know, they don't put us on the news as these immigrants, but we have our own issues that needs attention. And I hope bit by bit we can crack a hole in these churches and partner up with some sensible ones and make a change. Yeah.
I wanted to add that I actually attend a historically Black African-American church, and they actually have those programs in place. They do the exercise forums, they do the cooking classes, the diet. And I think the African-American church is actually one of the strongest and most reliable places you can go to get the message across, whether it be education, whether it be health, whether it be diet. It's really a good place to start. And there are those that are doing it, and it's been impactful. And so I think we need to get more of them on board. I think the dynamics in this country is different than some of the other countries. So we have a strong advocate in the church. It's just a matter of finding the ones that, getting more of them on board so that we can get more of these programs going.
Yep. I just want to add to that. I think one thing is that we don't teach how to think critically and how to defend against just bad information. I mean, it's an information warfare, you know, alternate facts. You have to be able to sift through and to be able to establish what is truth. And by not giving people the tools to how to do that, we become vulnerable to just, you know, any type of information that comes, whether it's across the pulpit or whether it's coming from the television. It really becomes a matter of how do we begin to think critically? How can you assess and how can you weave through this this new era of this misinformation?
Absolutely. Misinformation is now one of the biggest problems of our time. And I guess education is the counter operation which we need to put out there. And that's why Hacsa is having webinars like this. We've run out of time, but we have one more question from Kwesi, which I'll request GT to read out. I think that question would be the last question to the panel. So each of them can give about 1 minute answer to the question. GT, are you there?
Sure. So he wrote, if there continues to be spikes in corona, do we believe there will continue to be a stress on medical resources and medical workers?
Yeah, so I think this question is addressing the future because as I think Dr. Ismon said, some people are saying it will be around for 2 years, which is a pretty long time. And some say it will never go away. So how do you see the future of medical care in your community with corona lasting for at least 2 years? And how are you going to cope? Do you think you'll be overwhelmed, or do you think you'll reach some kind of new normal? So can we start with Dr. Rumbi?
I think we will come to a place of new normal. So I think the biggest benefit that occurred with the shutdowns that happened was getting enough time to build resources, to get protocols in place so that hospitals had good ways to protect healthcare workers, had enough supplies to cover the upcoming period, and to develop some treatment strategies. So I think part of the improvements we've seen is the time that people have had to develop and see which medications work, what ventilator strategies are most effective. So I think we are coming to a new normal. I think everyone has adjusted. And I do think if everyone takes on the preventative strategies, especially mask wearing, hand washing, avoiding that social contact as much as possible, I do think that the current resources will be able to carry us through up to a point where a vaccine is available.
Thank you. Dr. Ismon?
Yeah, I think that we are in a global experiment where everyone's done different things, but we can learn from who's done the best things, a bit like the lady said about the churches where they're doing really good work. We can learn from that. And if I look at Turkey and if I look at Germany, I feel very comfortable with and Ghana actually, the intelligence that has been applied to this. So test and trace is really important. As Hugh says, England or the UK has certainly screwed things up on that, and it's appalling for such a developed nation. But test and trace is really important. So the faster we can get better testing, and that's coming, we can track people, we can then spot those who've got disease early before they need a ventilator. Because really, once we lead people to ventilators, we're almost saying, go to die. So we don't want to do that. We want to find people way before they need the ventilator, give them oxygen, all the other supportive therapies that they might need, and prevent them needing ventilation. So I think these are the lessons that we're starting to learn, and the faster we can do those things, the better the prognosis for the future. So I think that, as the doctor said, it's a new normal, but with intelligence, we can manage this very well, I believe.
Thank you. Yeah, so Naomi Coppage.
Thank you. So I think we've learned a lot. When we started, we were scrambling, didn't know enough. Information was coming to us and we're making changes as needed. Our staff are tired, and that's the truth. Our healthcare workers are exhausted. Right now, we're actually in the mode of mental health. We are getting them to have meetings and talk about just the stress of doing it over and over again. And the thought of even more patients coming back is extremely difficult for them. So we're working through that and preparing, but at the same time, we are preparing to have, PPE was critical for us. From day one, we actually pulled everything from stock on our units and put them in a command center to manage it, to make sure that staff have PPE. So, and we're constantly sourcing to make sure that the PPE is available for staff to have it. But really, what if we can just get more of our friends and families to do the basics over and over again, wear the mask, social distancing, and hand hygiene, we will hopefully have more of a controlled environment going forward and not as much. And one of the biggest lessons we learned when we started was proning patients. Initially, we had started out thinking that all patients will eventually get worse and go to the ICU. And we realized, as Dr. Eastman said, they went on the ventilator, fewer were coming off the ventilator. We started proning patients in the medical units, and they were turning around getting better. So we've learned a lot more skills that I think we are better prepared going forward.
Thank you. And finally, Dr. Minta.
Definitely, the healthcare system in Ghana can't be compared to that in the US or in the UK. But we decided to put measures in place just to try and get ahead of the disease. And that is what has helped us, because we knew that if we were hit so hard by the COVID without any preparations, it was going to be a disaster or a massacre. So that was why the initial, implementations were sort of put in place. And must I say that even though we are doing well, we are not resting on our laurels, because everybody keeps talking about the second wave. And because of that, we are still, putting measures in place. As I speak now, they put various institutions up for testing. Because when we started, we had only 2 main places for the real-time RT-PCR. But now the measures have been put in place to have at least 1 big center for a real-time RT-PCR in all the regions of Ghana. So even though I should say that we're doing okay relatively, we are still trying to put measures in place, because as we're all saying, it's a learning process, it's a learning curve, and we don't know how things are going to go. It's just going to stabilize, but who knows, if there's a second wave or there's a second hit, then we'll be in trouble. So measures are still being put in place, and now we know more than before, so we are better prepared than before in case there's a second wave.
May I just very quickly add that there's a company called MoLogic that has been funded by the Gates Foundation, and they now have a IgM very good antibody test that looks very promising, and they also have a lateral flow swabbed coronavirus antigen test, which means that you could literally spit on this strip and it will give you results in about 15 minutes. So they're just waiting for all the approvals. So this is the level of the advances that are coming, and once we've got those, we are way ahead of where we are now.
Brilliant.
I would want to add that last week we started the IgG testing in Ghana, in West Ghana Medical Center. And we basically are doing that to compare it to the results we get from the real-time PCR to see if it can be trusted. So far we are waiting for results. And if that is good, we'll implement that too as part of our treatment.
Thank you very much. So today we have heard that racism is a factor in terms of the death rate amongst diasporan communities. Being prepared for the virus made a lot of difference in Ghana. Test and trace, early treatment, free healthcare when it's a COVID case, and enforcement of curfews and mask wearing were also very critical. We've also heard that within our communities, we must also focus on self-care, diet, exercise, and just all the activities which are going to help us to boost our immunity and protect ourselves and be strong in the face of a pandemic. We've talked about exhaustion and mental strain of COVID, mainly on healthcare workers, but on the general population as well. And in fact, we had a webinar on healing the last time, looking at the strain that communities go through, both because of racism and because of their disadvantage in the war against the coronavirus. Thank you to our panelists, and thanks to our audience for joining us today. Hacsa aims to bring the diaspora together to discuss issues that will support and enhance our communities. You can sign up for future information at our website. So the Hacsa Foundation website is www.thehacsa.org, and the Hacsa USA website is www.hacsa.net. If you Google Hacsa, you should be able to find us. Please give a donation to Hacsa to help us continue our good, important work. Thank you again for everyone. Thanks for coming. Goodbye.
Yes.